Hello, and welcome to Transforming Digestive Health Through Innovation. I'm Gina Konstantakopoulos, VP of Partner Strategy and Innovation at Matter. For those of you who aren't familiar with Matter, we're a healthcare technology incubator and innovation hub on a mission to accelerate the pace of change of healthcare, with a core belief that collaboration between entrepreneurs and industry leaders is the best way to develop healthcare solutions. We've incubated more than 1,000 startups since we opened in 2015, companies that range from very early to growth stage, and we have a suite of services to help at every stage of development. Our member companies have raised more than $5 billion to fuel their growth. We also work with large organizations such as health systems, life sciences companies, payers, and associations to help them innovate more effectively. In addition to providing insights and training, we run accelerators and partnerships with large companies to help them build the right collaborations with the right entrepreneurs. The AGA Incubator represents exactly this kind of powerful partnership. Working with the American Gastroenterological Association, we're sourcing and advancing solutions that directly improve care for people living with digestive diseases. This 6-month program provides 10 selected startups with monthly private workshops, exclusive one-on-one mentorship, and invaluable networking opportunities with industry stakeholders. Applications for the AGA Incubator close this Sunday, September 21st at 11:59 p.m. Central Time. My colleague Kay has dropped the application link into the chat. For today's event, we're thrilled to be joined by 5 leading voices in gastroenterology to explore how innovation can revolutionize the care experience for individuals living with digestive diseases. Our moderator for today's event is Dr. Jason Samarasena, Chief of Gastroenterology and Hepatology at UC Irvine School of Medicine. Dr. Samarasena is an interventional gastroenterologist who has pioneered innovative endoscopic treatments, including incisionless surgery for esophageal cancer. He's been named Physician of Excellence for 6 consecutive years and currently serves as president of the Orange County Gastroenterology Society. Jason, I'll turn it over to you to guide today's conversation.
Gina, thank you so much for that really kind introduction.
You're welcome.
It is really my honor to be here with an exceptional group of individuals who will, over the next 50 minutes, have really kind of an informal chat about kind of where we are. And this session on transforming digestive health through innovation is just another example of kind of what the AGA is doing. I've been a member of the Center for GI Innovation and Technology, the CGIT, for several years, and I'm really, going to say it. I think this is really kind of the place for innovators. I remember the first time I went to the AGA Tech Summit, I really felt like, oh my gosh, these are my people. And I think some of the panelists that you're going to meet today, I think you're going to be inspired by them and their stories. So why don't we just kick this off? I would like to invite all the panelists to share their video, and I would like to introduce them all to you. And I'm going to start with Dr. Eric Shah. Hi, Eric. Eric serves as the innovation champion for University of Michigan Innovation Partnerships. He's director of Michigan Medicine GI Physiology Lab and is the associate professor of medicine with expertise in esophageal motility and reflux disorders and pelvic floor disorders. Eric, welcome.
Jason, glad to join today. Thank you.
Next up, we've got Larry Kosinski, who self-nominated himself as being the oldest person on this panel, but certainly also probably the wisest. He has a long, successful career as a gastroenterologist, actually, finished his career as a GI and then really has been a serial innovator in our field. He has founded Sonar MD, the leading value-based care coordination solution for complex chronic diseases. He is currently the CMO of Jonah, a AI-powered company focusing on bringing personalized microbiome knowledge to the public. Larry, I've known for a number of years. He's on the AGA governing board, and in 2022 serves as a counselor at large for development and growth. And his term as counselor concluded in May of 2025, but has been really actively involved with the AGA and the innovation mission. Larry, it's great to have you.
Thanks for that intro, Jason. It's humbling to be on this panel, and yes, I am the oldest one, and hopefully there'll be some wisdom involved there. The only addition I have to my intro is I currently am also involved in my latest startup, Volucnomics, which you'll hear about sometime during the webinar today.
Thank you. And then we have an amazing, I'm going to call it power couple. And I'll start with you, Vetri. So Dr. Vetri Elango is the co-founder and CEO of Arithmedics. He holds a PhD from Georgia Institution of Technology and brings 18 years of experience building AI and data products. Most recently, he built an AI decision engine at Google. At Arithmedics, he's developing an AI coding assistant that acts as an intelligent co-pilot for medical billing. Vetri, good morning.
Good morning. Thanks for the fantastic introduction. Special shout out to AGA because when we founded this company, we first tested the idea at the AGA CJET Shark Tank, which we were happy to win. So thanks a lot. That has given us a unique opportunity to get in front of all the gastroenterologists whom we are trying to help. Thank you.
Vetri, thank you. I was our AI startup also participated in the Shark Tank a few years ago. We didn't win. We lost out to a smart toilet seat. So that was too bad for us. And last but certainly not least, Dr. Renu Dhanasekaran is actually Vetri's wife, and but a highly accomplished board certified gastroenterologist and hepatologist specializing in liver cancer research and patient care. She completed her fellowship at Mayo Clinic in Rochester and earned a PhD in cancer biology from Stanford University, an extensive publication record supported by grants from the NIH and other prestigious foundations. And she's also a co-founder in Arithmedics. And we're going to learn a lot more about their story in innovation together. And you know, I think, you know, with that, Renu, welcome.
Thanks, Jason. Yeah, great to be here. Always found AGA such a forward-looking and innovative place. So super excited to participate in this conversation.
Perfect. No, really, really honored to have you. So I just want to, you know, add to what Gina kind of mentioned about the AGA Matter Incubator. This is, in our field, the first of its kind, as I'm aware, and it really is an exciting day that we can, you know, partner with someone like Matter who has just such an extensive experience in the realm of helping, you know, young companies reach their potential. You know, I was part of a similar effort at with Y Combinator, and I can just tell you what a great experience this was, and to have this now, you know, GI focused incubator, you know, it's just amazing. So very, very excited to have partnership with Matter, and looking forward to seeing the applications as they roll in before Sunday. All right, so why don't we, you know, get the panel discussion started, and I'm gonna start with a question for Eric. Dr. Shah, can you paint a picture for our audience of the current state of digestive care, and what are the most pressing challenges patients face in their care journey today?
That's a great question, Jason. So, if we start with the patient who has a medical problem that affects the digestive tract, um, from the patient perspective, it's between the diaphragm, so that's the muscle that separates the chest and the abdomen, and then down to something right above the legs, okay? And all that area is digestive health, right? The physicians might have a different perspective. It's a bit more complicated than that. There's muscles around the organs. Each organ has a different specialist. The physicians are sort of hyper specializing in various different things. We're seeing a trend towards primary care being underfunded. So they're sort of beholden to whatever mechanisms are available to support having nursing staff, having scheduling staff. There's mandates. They're now 10 years old to transition to electronic health records. The idea of electronic health records and actually HIPAA, if we go back to what HIPAA was designed for, is portability of electronic health records, and has that panned out. So it's sort of this complex system. Ultimately, the patient just wants to get help for something and doesn't really know where to go and doesn't know who to call. And this sort of model of having a primary care hub with specialists around it to consult sort of isn't working right now. And so, not really sure what to do. I think a lot of the health systems are, and I see the UCI, there's Michigan behind me. They're doing a lot. It's a different sort of model that they're setting up right now to serve patients. So, a lot of confusion when patients kind of have that problem, who to see, where to go, how to navigate, and get through the system. There's a lot of potential cures out there that are proposed. How accurate are those? Now patients can get information within 30 seconds. So it's really ripe for information, misinformation, coordination of care gaps, and things are expensive. So you might get your care and then 6 months later get a whopping bill and lose your house. So a lot of things to navigate. And I see there's 60 people who probably have some personal story that kind of brought them into the room today. So just kind of set the stage for all the potential things we might talk about. Jason, thanks for the question, and hopefully that helps.
Nick, great great overview. And Larry, speaking of some of these gaps that Eric mentioned, from your perspective, where do you think the biggest gaps are for what patients need and where the current health system delivers?
Well, Jason, I really see it falling into three major gaps. The first one is the disparity between reactive and proactive care. Our current system today waits for patients to seek care for a symptom or a condition, which really is flawed in two ways. Number one, are the patients really capable of telling when they need care? Do they really know when they're going off the rails? And the second part of it is we're always behind the curve. But if we're waiting for illnesses to develop before we intervene, we are always going to be behind the curve. What we need is a proactive, high-touch care system, which applies to both primary as well as specialty care, so that we can intervene early in the course of conditions. We really need to move ourselves in that direction. Secondly, the second major pillar here is our fee-for-service payment system is archaic. It was designed in an old world. It's really not focused on what we need today. As Eric said, we're not paying for primary care. I'd like to divide it into cognitive versus procedural. We're not paying for cognitive care. That's the issue, and that goes across the primary specialty care barrier. And frankly, everybody, we're overcompensating for procedural care. Come on, we're undercompensating for cognitive, overcompensating for procedural, and we're penalizing proactive care. CMS comes out with CCM codes, PCM codes, which are preventative codes, right? We're supposed to be intervening preventatively, and yet we charge the patient a copay. what patient is going to pay a copay for a preventative care going forward? It just doesn't make sense. If it's preventative care, it ought to be free without a penalty of a copay, because you don't want to discourage preventative care. If it was up to me, I may need a remote start for my car and a food taster, but I would freeze fee-for-service payments where they are right now and provide increases in compensation for value-based care and for outcomes-driven care. This old system we have is really hurting our ability to fill gaps. The final pillar here is there is a major disconnect between what the patients, what the public is seeking in their care, and what the system is currently delivering. A vacuum exists today that is being filled by alternative medicine care, functional medicine providers, integrative medical providers, alternative forms of care. An entire industry has developed that is off the grid and is not being compensated with insurance, but is being paid out of pocket by patients because the current system isn't supplying those needs. We need better to identify these market needs and provide solutions.
Larry, amazing, three amazing points. And Larry, like, don't hold back or anything, just this is great. Just kind of switching the focus to kind of really what this session is about, innovation technology. I'd love to hear from the team at Arithmedics. Arithmedics is working at the intersection of data science, digestive health, and can you share a specific example of how technology is solving real problems for GI patients that traditional approaches really couldn't address?
Yeah, so that's a great question. I can start a little bit of the patient perspective, I think, and Vetri can talk about the data science perspective. So to agree with, to take off from where Larry and Eric left it off, I don't think the current challenge per se for a patient is that, oh, my doctor doesn't know what he's doing. And a lot of the technology seems to be like, oh, let's replace the doctors with algorithms and, data solutions for that. I really think the problem is they cannot get appointments. They cannot get parking when they get there. They don't know how much they're going to pay. The doctor doesn't know how much they're going to get paid. And, they don't know whether there's prior authorization. So I think it's all the financial distress around a clinic or a, hospitalization that we really need to alleviate, beyond the medical care. I really think as doctors, we know the treatment. We know when our patients see us what kind of medical prescriptions or procedures we're going to do. Even for us to get it scheduled to make it happen is like making 10 phone calls and, 20 epic messages. So I feel the system needs to become leaner, faster, and more efficient. And that is where Arithmedics is focused to make patients' life better.
Okay, to chime in on that, right? One of the things I've heard, and I'm a technologist at the end of the day, right? What motivated me to get into this was I see a system that's in the dial-up age. We are in the iPhone era, and that's the healthcare experience that patients should get. And that's what motivated me to start Arithmedics, right? And coming back to the data science aspect of it, because at the end of the day, data is information. And in healthcare, data systems are siloed, they're not connected. This puts a huge burden on everybody. All the pain points that Renu was talking about, or Dr. Kosinski and Dr. Shah were talking about, is about, at the end of the day, information flow, right? That's not happening smoothly. And the decision makers not having the right information when they're making the decision. And I think that's kind of primarily what Arithmedics is trying to solve. While our first focus area is in the billing, because we believe that it fundamentally affects how providers provide care, how much time physicians spend on paperwork, and also touches everybody, because eventually, we're all paying for healthcare, either like through our insurance, or even if our employees are paying, they are taking money from our paycheck to pay for the higher cost of insurance. So we think like this is the right place to start to have the best impact on everybody. That's kind of our philosophy. And happy to dive into more of the technical details about it, but I think that's probably not the idea of today's talk.
Vetri, thank you so much. I, 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 but what does that actually look like in practice for someone managing sort of chronic disease conditions, and how can innovations make care truly centered around patient needs? And this is open to everyone, but Eric, any thoughts on this?
Yeah, so the challenge I see, and sort of the solutions that come out, the solutions that sort of get created, and this kind of I think touches on the digital health space. So think of like health tech, it goes by various names, changes every few months. But I think the solutions that come out sort of fix the problems of today. From a venture standpoint, if I'm looking 5-6 years down the line, what are those challenges we're going to face tomorrow? Sort of introduces a level of risk. And so, those solutions today might need to be a bit more nimble, and that sort of thing. It's interesting because I think that the gaps, and Renu touched on this, is communication. And if we communicated better, we wouldn't need an AI tool to help us do that, because we're too busy and too burnt out to talk to each other and pick up the phone at a high level. So, it's something that, I noticed in a previous job. So, and it's kind of made me, question the value, I think, of not the digital health space entirely, but just maybe the way we're thinking about some of these strategies. Could they scale better if they had a different set of assumptions around trying to help physicians communicate better, not only with patients, with each other. And it goes for staff too. And it just gets at this concept of, well, we don't have time for that, so I need to silent my meetings, have monthly meetings, things like that. It's interesting. One thing I also think about is team size. So, the best teams are no more than 8, maybe 10 people. They're on 8 people. So I think about the number that are on the panelists on this call, including everybody here. That's the team size. Once it gets bigger than that, that's hard to scale. And so, I'm actually, wondering, we do see these, this consolidation in healthcare at the moment. But, is private practice going to come back? Could you have more nimble teams delivering healthcare better, faster, stronger than any of these big shops? And what are these big shops really for? And I think that we think things won't change. I always go back to the same old story of Apple starting through Xerox at Park. And just think about that, and how Xerox really started off your iPhone. If you look back at sort of the history of that, MS-DOS and IBM and all that, it was the big shops, and just how much transformation has happened in that time. So so I would, suggest, don't be afraid to think big. Think about your core set of assumptions that you're making for your business model. And I think it's okay to make assumptions that may not be true today, but that you believe in, or sort of what that practice could look like tomorrow. And if you don't do that on this call, it won't happen, and we will be stuck with where we are today. So, so I think it's okay to sort of be bold in those, some of those assumptions that you make.
Great, great answer. Does any of the other panelists have anything to add? Larry?
Yeah, I'd love to pipe in on that word big, because it's where my head is going with this as well. From our training, we pigeonhole ourselves into a one patient at a time thought process. I always said that, I don't even think about the last patient I saw when I get the next patient in the room. But if we're really going to analyze, we have to come back out, think big, think population based. And the typical GI practice, whether they're in private practice, whether they're hospital-based, academic, really doesn't practice population health. Our EHRs are designed for one patient at a time. The practice really doesn't have solid data on the demographic needs of the community it's trying to serve, the age, gender, ethnicity, illness prevalence. They don't know this. And we don't have information systems that help us match supply and demand in our practice. So as a result, patients seek care where they can get it because oftentimes they can't get it locally. What we really need is population-centered care. How do you strategically build your practice unless you know the needs of the population you're trying to serve? The technology is out there. We just need to tap into it. And, you know, I would advise all of you who are in practice and trying to innovate at the same time to remember that work is a gas. It will expand to the space you give it. And you have to decrease the container of your workspace so that you can then focus on the innovation that you want to pursue. If you're waiting for open time in your day, it's not going to happen. Somebody's going to fill that up. And so you have to be a little bit selfish here if you want to think about innovation in your practice and in this expenditure of your time. Remember, work is a gas.
Larry, being a microbiome expert, that's very fitting for you. Also, I'm going to steal that. That's a fantastic line, and conceptually, it's really it holds so much truth. Renu, anything to add on this topic?
Yeah, I think the topic on innovation, and we are here all talking about it, and there is also a reason why there's a lot more excitement around this space with AI coming in the last few years. So I think that's, we've always wanted to bring innovation, and I think it's a big part of all our research for sure. But it does feel like something shifted in the last year. There's so much discussion on AI, and there are so many companies and large players from Amazon to Apple, everyone entering the healthcare space. So I feel as physicians, as the primary, guardians for our patients, and as, healthcare providers, I really feel we need to be on the table. That's one of the main reasons, I was motivated to join this entrepreneurial journey, because I feel for a really long time we've been passive and products have been given to us, and then we sit around tables and complain about them. I think with this AI revolution, it is possible to participate. It is democratizing technology to a great extent. So that's why I'm really excited about this chapter and what AGA and Matt are also doing to bring in such kind of Shark Tank and startup accelerators, because I really hope that a lot of gastroenterologists jump in and like Larry said, find time, make space. It's time to innovate.
Awesome. Vetri, anything to add?
Yeah, so I'm actually going to talk it more from a patient-centered care, because I mean I have more exposed to the system as a patient than than being on the other side of the thing. One of the things is, as technology and AI come and start playing a bigger role, I see the future of work as who is going to win is the people who are going to make it more human-centric. Right now, going back to what Dr. Shah mentioned, there's an interesting statistic we came across as we were doing. In healthcare, there are 10 non-clinical administrators per physician. And that's kind of the system overload where people are trying to do so many things, so much of paperwork and all these other stuff, that they don't have time to give that human touch to the patient encounter, either at the front desk or anywhere else, right? Forget even the gastroenterologist, that's like secondary, right? I think the future is there is an opportunity with technology and AI to actually truly make it a human-centric, patient-centric, where the patient is the focus of the healthcare system. And I think that is where we should all try our innovations to go. It not just be AI, right? Anytime you help, like any device that could make the patient experience much better, like by making sure that the physician has more time to do the human touch, I think that's going to help as well. So all aspects of technology.
Awesome. Eric, from your research perspective, what digital health innovations do you believe will be the most transformative for patient experience in the next 3 to 5 years?
Yeah, I'm not sure. I'm really not. And, are the products something that people want, and then who are the people that are going to use it? And that the saying that most of the time the product fails because it's not what people wanted in the first place. I'm not actually sure. I think the back end, I'll call it the back end, is probably where we're going to see the majority of successes that are can think of as more straightforward. The reason is it's not the thing that looks cool. Like it won't, it's not a, say, AI platform that will talk to you and converse with you and tell you how to treat your disease better. And if it does its job, you won't even notice it. And that's sort of the point. And so how do you build a product that nobody knows that they want nor care about, ideally, but that when the bad thing happens, such as, let's say you receive a bill 6 months later that's erroneous, and you have to fight that for 5 years after that. When you receive that bill, you're mad. When you don't receive that bill, you don't know that there's something out there that helped you. So, and I think that's where the value is going to be, is in spaces and products like that. I think that the assumption of AI and patient-facing care would be that the generative AI would have to be so good that it could essentially replace that cognitive component that the public is at the moment not willing to pay for, based on the set of assumptions that go into how reimbursement flows and how the money works. And I think we all have challenges with accepting that. And so I think that we're going to have to take a look, exactly as Larry said, on the cognitive component, which is important. I do think there's value in the 10,000 hours it takes to become an expert at anything. I do really think that there is some expertise to be had that can't be found in an AI algorithm that's trainable. There's always something missing. It's good at 99% of situations, but the whole point of becoming an expert, so a physician, for example, is that you will be able to catch and have seen that one-off. So those are sort of the challenges I have with some of the patient-facing side. Some of it, might be easier if we draw boxes around things like that. Now we're seeing the ramifications of drawing a box around, say, a finding on an image. And then there's a recent study out that shows that physicians become less competent in looking for polyps on procedures where they have activated the boxes in the past, which is an interesting phenomenon. We see that in pilots, so in the design of cockpits, the design of cars. So I'm sitting here next to Detroit. Whenever they design a car and there's an instrument panel, it's all about attention and where your attention is going to go and what it's going to take away from. So, different things we can learn from different industries. I'm not saying that those industries, at least for GI, are going away. They're definitely not. But just as we iterate these products, we'll have to think about that aspect of things too, for sure. So I see Larry might have some comments as well. So, but I'm going to stand on the back end is probably where we'll see something really transformative.
Great, Eric. I know the de-skilling after exposure to AI assistance is kind of a new concept that we haven't really thought about yet, and that's coming to light recently. So kind of switching gears a little bit to implementation and real world impact. Larry, this question is for you. When you look at emerging technologies, what factors determine whether an innovation will actually improve patient outcomes versus just adding complexity to care?
Well, I love this question. So often the technology is developed, which then it might be cool, but it has to be retrofitted into the care infrastructure in order to build a business model around it. It's almost like we have an innovation. Is there a business that we can build for it, instead of the other way around, saying what does the industry need and how can we provide this solution? The technologies that have to be retrofitted typically, and excuse my dog barking, typically don't get the traction that they should. The best technological success arises when you provide a solution to a patient problem that they actually want. Just look at the explosion in GLP-1s. Patients are actually seeking this out. They're buying expensive medicines that they're injecting into themselves once a week. Why? Because it works. They never did this with bariatric surgery. There weren't lines at the door for the bariatric surgery programs, whether they were surgical or endoscopic. So if you find something the population needs, your innovation is going to thrive. So we need to provide the care the patients want at the time and place they want to obtain it in the most cost-effective way possible. We need more virtual care. We need more on-demand care. We need more wearables. We need more AI-driven healthcare information. I love what Eric said about cognitive care. Okay, here's an example. If I was in a practice where I had a group of, let's say, IBD specialists, and they were predominantly only seeing IBD, and they were going to the meetings, they were following care pathways, they were providing cutting edge IBD care. I would provide these doctors with ambient recordings that would maybe create their notes for them, do their coding for them, make their lives easier, because I want all those WAV files. I want every one of those WAV files, and then I'm going to overlay a large language model on top of this thing to create a product where I can extract that cognitive knowledge from this group of doctors. Then I'm going to sell that. I'm going to sell that to at-risk primary care groups. I'm going to sell it to ACOs. There's a product right there that the technology exists to build. It's just a matter of matching it to the needs.
Great. Dr. Dhanasekaran and Dr. Elango, what challenges do you face when trying to integrate data-driven solutions into existing clinical workflows?
Yeah, so if I may start off, so I think the main challenges, we've touched upon it. It's a system that was built for a different era, paper and pen era, dial-up era. And there are multiple software or systems we all use. We use one for patient records, and then there's a practice management system. And you will be surprised, but there are Excel sheets on which your practice managers are maintaining some data. And then now you're saying, hey, if you bring the Silicon Valley mantra of move fast and break things, you suddenly will come into healthcare and you'll realize, well, this is not what you're expecting. You have all these systems. So I feel we need a system that's very fast and agile and nimble, but also accurate. This is not the kind of industry where you can just move fast, break things, and then be okay because you have patient lives at stake. The information needs to be precise and accurate. And again, for us as healthcare providers, we are responsible for what happens to our patients. So I think that's where the tension is in healthcare. A lot of health tech or companies come in who are not really immersed or well aware of how healthcare systems work, and they're applying something from a different vertical straight on to slap it onto healthcare, right? And then we've seen huge companies actually fail to transform and then fold shop and go home. So I think that's the big challenge, that this is a system that's already in place. You can't say uproot everything, throw it out and take my new product. We've all invested millions of dollars building the current system, and the system has to be accurate and gold standard. We cannot take almost there 90% okay, because that 10%, the 1% can make a big difference to patients. So I think that speed and accuracy, how do we get that, and how do we still keep the existing systems somewhat while we incrementally improve stuff? I think that's how I look at it.
Great.
Jump
Vetri.
on that and chime in, right? Interesting thing that all my three co-panelists brought up here is it needs to be silent in the background, right? Where it's something, it works so effectively that you don't feel it, right? It is something that takes away, the cognitive load and other things, and make sure the system is seamless. And last but not the least, what Renu said about accuracy, right? One of the interesting things I've learned in this journey, right? I mean, or as a technologist in general, is people are very forgiving of human errors, even though, the healthcare system, we all know there are multiple errors that happen in everywhere else. When it's a human who does the error, we are all very forgiving. But if it's a technology solution that comes in and does even 1% error, we are very, very critical about that. That means there's a higher bar when you deliver a technological solution, number one. right? And going back to the other thing is, as the innovator, how do you build a scalable product, right? Because even within a same practice, not every physician or not every staff member will follow the same workflow, right? They all have different ways of doing things. And if you're going to automate something, how do you scalably build something that's going to fit everybody's needs or everybody's style of working, right? So those are some of the critical factors that actually go into as an innovator on, like, how that's one of the key challenges for you to overcome if you want to build a successful product. A successful product is one that works very seamlessly, not visible, and essentially it just makes your life better without even you ever recognizing. It's like, I don't know, the best thing I can say is I can't think of life without Google search. It's such an integrated part. If I don't have access to it, I'll miss it, but I don't think of it every day.
I like that analogy. Eric, question for you. Being in academic medicine, what role should academic medical centers play in validating and scaling digestive health innovations? And how do we bridge the gap between promising research and widespread clinical adoption?
So I'm going to push back and say none.
Okay.
And this is interesting. The challenge, the universities are supposed to be generating new science, right? When you put the scaling under the same umbrella and shop as the developing, it's ripe for a lot of issues and misuse. And so I think it's, what I've seen when you look back at what are the innovations that are most successful, are the ones that are able to connect into the ecosystem. So this is where I think, programs like Matter come in, where it's less about the organization itself. It gets kind of murky there, more about the invention. So I would say that in terms of long-term success, the role probably is best left to sort of the broader ecosystem, rather than to the academic places themselves. They're good at what they're good at, and they're not good at what they're not good at, right? So when you think about a nonprofit, so a university, the university will never exist, right? It's a different set of incentives. When you're in a business, there is, you might go under. And because of that, you're going to be incentivized from a different perspective. When you're a private practice physician in the community, you live in both worlds. And so you might go under from a business standpoint, you still see your patients. And those two are intertwined. So when you think about sustainable care, sustainability, that has a few different meanings, and that's important. Okay, so whereas I think from the academic side, that sort of incentive, it really isn't there. You can't, like, these universities aren't going to close. And so, on one hand, are they going to be able to take on some level of risk? Sure. But it does, it might create sort of a perspective where you might do really well in that setting, but it is going to be harder to scale. So I might actually suggest, maybe not looking to the academic centers, even potentially long term, to really do this. I just caution, because I think there is a trend towards that, and I think we might look back in 20 years and regret it.
Great response, Eric. I actually couldn't agree more. We have a question in the Q&A specifically surrounding the Matter AGA Incubator, and maybe we can ask Vetri and Renu to talk about their experience, because they were, as part of winning the Shark Tank, were recipients of a 6-month mentorship program through Matter. And would you be able to, share with us your experience through the program?
I can go first on this one. I think it's a fantastic program. So they have a huge knowledge base and like how to go build a company. How do you think about these things? They have excellent resources in terms of mentors and network that we found super valuable when we were part of Matter Health. And the kind of introductions we got and the follow-up meetings, like once a monthly meeting, they also helped us a lot with delivering a story to the investors, which I think like pretty much is on the top of mind of every innovator. So we actually found their program very valuable, and then we moved to a different stage in our company, and then we continued building with other things. But it was a fantastic thing, and I would highly recommend that. And actually, I think having more of a AGA incubator that's in a partnership with AGA and Matter Health makes it even more of a stronger program in my opinion, because Matter is more healthcare oriented, but when the AGA incubator brings the gastroenterology focus, and definitely if that's your market, I think that's a great opportunity to get started.
Awesome. Renu, anything to add? And also, was there some in-person components to it, or was it largely kind of virtual?
I think when we were at CJET, the initial CJET shutdown happened in Chicago, so we did meet some of the people that matter. After that, a lot of virtual engagement, and today, how the way the world is, it's also small with the virtual engagements. Yeah.
Gotcha.
I would add to that one thing. It is not that they don't have in-person events, like because we are so far away, we we prefer the virtual events. So they do have those events, and there is a wonderful opportunity, especially if you are in the Chicago area.
Awesome.
I have to make a comment here because Sonar MD got its start at Matter, and I brought the AGA and Matter together for this. My experience at Matter goes back all the way to 2016, and I had started Sonar, a little tiny company. I basically was sharing a big long desk with a bunch of kids, people that were half my age, starting up companies. But I like to look upon Matter as a beehive. It's a center of activity. So not only do you have young companies that are trying to innovate, you have large corporations that are looking to connect with young innovators. So inside Matter, they had this big wall of these signs of all the names of all the companies, both the startups as well as the supporting major corporations, and they basically bring them together. So there were always presentations, lectures, educational pieces. But one day they brought a major investor in that held a Shark Tank. And I entered the Shark Tank, and that got me my investment in Sonar. So Matter was really influential in the growth of Sonar.
Awesome. Thank you, Larry, for that endorsement. And it really is an amazing resource. And Larry, thank you for everything you did to bring this together. Really, I think it's going to be transformative for so many kind of young companies needing this. If I could switch gears a little bit to kind of the future, and this is for really all the panelists, and maybe we'll, start with Eric. But if you could wave a magic wand and solve one systemic problem in digestive healthcare delivery, what would it be, and how might innovation address it?
Yeah, it's a good question. I think that the discrepancy between what patients think what they really want, which is ultimately what matters, pun intended, versus what we think we're delivering up front, would save a lot of costs. And I think that sort of, not even patient education side, but setting up the consult for success would be an interesting area. I don't have a solution for it, but that's the whole point. So I'd suggest someone look into that and solve it, because that, no matter what we specialize in as physicians, this is a daily struggle. And I think that I guess to get to the point, I'll call it environment. When you look at what Matter is able to support with this partnership with AGA, that's sort of independent from an organization who could be your customer, I think that's sort of where you want to look to be able to do that in this beehive, essentially. So yeah, I'm a strong believer in this concept as an outsider to it, for sure. And that's exactly why I'm here today.
Awesome. Larry, one
Well-
systematic problem.
Well, a couple things. First off, we need to fix the payment structure. That's really what's holding a lot of things back. I sit on the PTAC, the Physician Focused Payment Model Technical Advisory Committee. We're a committee of HHS, and I've been on it for the last 4 years, and we keep hammering and hammering and hammering. Our current payment structure is not set up to help us innovate. Now, if I was waving a magic wand on one solution that I think could revolutionize digestive healthcare, like we have to go to diet and nutrition. So much of our population is obese, suffering the illnesses that arise from it. So much of the population has very limited knowledge of nutrition. We make them pass a constitution test, but not a nutrition test to graduate high school. Most people don't understand what they should or shouldn't be eating. Our food industry is built around generating profit, not generating health. And we at Vocnomics are working on a solution for this. We have a simple little device, an eNose that sits in the bathroom and passively actually analyzes the air emitted with a bowel movement. We capture the most private 15 minutes of everybody's day and send that to the cloud, have AI analyze it, and we can tell people whether they're eating the right amount of soluble fiber. It's got applications for obesity, IBS, IBD, MASH, others, but the magic wand I'd love to try to wave would be to get people eating the right way so that they can be as old as me and feel as healthy as I do. So that's my magic wand.
Awesome. Renu, any thoughts about one systemic problem?
Yeah, so I personally feel we just need to go back to the basics. If I have a stomach pain, I should be able to see my gastroenterologist tomorrow, do the endoscopy day after. On the clinic visit, the doctor should be paid, my insurance should pay them, and I go home with my recommendations, right? It should not be that I'm waiting 6 months and I don't know. So I feel automate healthcare administration, let the doctor be with the patient and the patient and the doc, I think just back to the basics. It's a very simple relationship. The only thing you're selling in this business is healthcare expertise of the doctor to the patient who's sick. That's the core, right? But I think we built so much around it that to just navigate and get to that core to get the help you need becomes like a maze. So I feel all this technology, if it can take away the overhead, the burden, and strip it down to the basics where if you need care, you go get it and it gets paid for, I think it'll just make the patient's life so much better and the doctor's life so much better, because honestly, we all train and we train for 15 years and 18 years or whatever we do now to take care of our patients. And then what do we do all day? We are typing away, we're doing pajama time and writing notes and submitting this and that. And no, I would love to be left alone with my patient. Let the scribe it, let some AI tool submit it, let someone schedule it. I don't need all the other, the work that I do. So I feel back to basics, doctor-patient relationship should be restored and administrative burden should be automated. Plug for Arithmedics. That's what we're trying to do.
Awesome. Kind of last question as we're kind of wrapping up the session. Looking ahead to 2030 and beyond, what will excellent digestive disease care look like, and how will the patient experience be different from kind of what we're doing today? And Vetri, maybe we'll start with you on this one.
Sure, fantastic. The way I would look like, hopefully by 2030, it might be too fast for what my vision of what it should be is going back to my initial statement. Healthcare is in dial-up telephone era today. It needs to come to the iPhone experience, right? You should everything should be seamless. Medical debt is one of the biggest reasons for bankruptcy in this country, and that's why solving the payments and making sure that patients are not overburdened, that's where our focus is, right? But we are hoping to expand into all of healthcare administration, and as Dr. Shah mentioned, like be in the back end, right? Automate the back end and make sure that everything goes seamlessly so that the physicians can take care of the patients. And for the patients, it's a seamless experience. It's as simple as going to Apple's website and ordering a iPhone and getting it delivered and having, like, a seamless setup and everything else, right? Because if you think about it, a lot of times patients do not go and get preventive care because they are worried about the medical debt. They don't know whether what will be covered and what will not be covered and all that stuff. I think that is where bringing a leaner, transparent payment system is the key first systemic problem we'd like to solve. But essentially transforming the entire system from a dial-up telephone to iPhone era is what we are looking for.
Awesome. I'm going to give the final word to Larry. I'm going to ask you, and Larry, again, thank you for everything that you've done for kind of our field, and the younger guys have really learned a lot from you, and you've really paved the way, and you still continue to kind of break new ground, blaze new trails, and we really appreciate you for that. And what you've done, to put all this together is really really just we applaud it and we appreciate it. So, but I want to hear from you. What will be different in the future, and how will the patient experience be different?
Well, thank you everybody for attending too. This is a fantastic session. Listen, there's a big difference between a magic wand and a crystal ball. And so this last question is more of a crystal ball question. And in light of everything going on today, and in light of what I heard Eric talk about, which was, to me, one of the most powerful things I heard, is, will the academic medical center survive? We have the technology to do just about anything we want to do. Having it is not the issue. Do we have the commitment to make a healthcare system that is good for every American? I think the biggest question here is, can we speak up, stand firm on what the right things are to do for the health of the people in the United States? We can't abandon science. Science got us here. And we have to invest in the people who are doing the research, who are taking the time to study everything. I'm an old guy, and at this stage of my life, the message I would like to leave everybody with is, stand for what's right. We got here with science. Science is going to carry us forward. We have to make sure that everybody benefits from it. Those are big decisions, and those are things that AI can't solve for us, but we can solve it if we all do the right thing.
Fantastic. And with that, Larry, Eric, Vetri, Renu, thank you so much for sharing all of your insights today. I'd like to thank the attendees that made the event, and please, for interested individuals, please apply to this program. It really is one of a kind. And I want to wrap up with a few things that I learned from this last hour, and a lot of them are yours, Larry. Proactive, high-touch care is where we need. Thinking about patient-centered care is great, but think about population-centered care. Technological solutions that work are the ones that are seamless and in the background. I think maybe there should be more of a focus on diet and nutrition. And your last word about investing in the people that are doing the science is so key. And I think I think we're all sort of feeling the same way about the future, and I think it's exciting. And I think these opportunities like the AGA Matter Incubator is one of the I think the steps forward to getting to our goal. And so with that, I'll close. Thank you, everyone. The AGA Matter. We really appreciate it.